We're going to be talking today about the guidelines and practical applications for artificial urinary sphincter. And as we go through this, you may think, wait a second, wasn't this talk literally just given 2 days ago? And partially that's true. This is going to be a little bit different, but what I always say to the residents is that repetition is the branding iron of knowledge. So we're gonna go through it anyway. My disclosures. I'm a consultant with Boston Scientific. They obviously are the maker of the artificial sphincter. I'm also an author on one of the guidelines. And these are the guidelines I'm going to be looking at. The first was published in Neurology and Urodynamics. This was a report of the 2015 ICS Consensus Conference, and this background was discussed by Dr. Westney a couple days ago. These are the group members. There's also a more recent AUA SUFU guideline from 2019. Authors are listed here. Okay, so the AUS should be offered to those with stress urinary incontinence that is due to intrinsic sphincteric deficiency, who have failed conservative management and who have sufficient dexterity and cognitive function to operate the device. This should not be done earlier than 6 months after prostatectomy if it's not improving, and it should be verified by history and physical exam. So on a practical level, I do see a lot of patients who are diagnosed with post-prostatectomy incontinence, but there is really no information whatsoever about the nature of that incontinence. And so it is important to take a good history and recognize that incontinence is not all stress urinary incontinence after prostatectomy. Of course, they should have tried conservative therapy, including pelvic floor physical therapy, etc. But the old paradigm was that you really needed to wait about a year, and a year is probably too long, especially with those with severe incontinence. Those who have gravity incontinence, they're not going to get appreciably better, and they should be treated earlier. You want to verify this in some way, so what I will typically do is after cystoscopy, I will have them do Valsalva maneuvers, both laying down and sometimes standing up, though I can really demonstrate it because people can sometimes say that they're incontinent, but maybe they aren't, and you don't want to do anything irreversible or very invasive unless you know what you're treating. Urodynamics, it's not always required. The postoperative cystoscopy, preoperative cystoscopy, is highly recommended. As we talked about a couple of days ago, it's not mandatory, but as you probably gleaned from the discussion, those who say it's not mandatory, their reasoning, I don't really like the reasoning. Often it's for practical matters that have to do with clinic flow and things like that. But I found you can always really accommodate this. A lot of my patients are from out of town. I'm sure that's true with a lot of you guys. And we just kind of make it work. It's important. You're looking for stenosis. You're looking for the quality of the tissue. You can get a pretty good idea of bladder capacity and whether they're having significant urge symptoms as the bladder fills, etc. I think there's a lot you can get out of it, and you don't want to find out on the day of surgery that you can't get a catheter in or that maybe you're doing the wrong procedure. Patient teaching. They need to know this is not one and done. A lot of them will have that impression that an artificial sphincter is something they do once and they will never need to worry about it again. But of course, that's not true. The consensus panel had said that the appropriate time period to discuss with the patients is about 5 to 7 years for longevity. And of course, there's a lot of variation on that. But patients need to think of this as a staged procedure for the rest of their lives. And they need to not only understand that, but accept that as a possibility if they're going to continue to use it. And usually once they have one of these, they want to continue to use it. They also need to know the rates of mechanical failure, erosion, infection. All of these things can certainly happen. Mechanical failure is much more common, but erosion and infection, especially in high-risk populations, this is a real issue. Preoperative challenges. We don't see stenosis quite as much as we used to in the days of open prostatectomy, but we do see it. As I'm sure you all see, many of our patients have had radiation as well, and that is a big risk factor for this stenosis. You can see here a list of all the other risk factors. Most of these are quite intuitive, but to me this is yet another reason why you should do preoperative cystoscopy. Now this is just a little algorithm for how we might go about dealing with stenosis. And we're of course interested in the left-hand side, the incontinent side. Those who have urethra that's in continuity, you want to do something. And there are various things that can be done, and I'm sure we'll talk about this a little more in the panel later. But in those in whom you're successful, it is reasonable to put in the sphincter. But the question is, when you do that, do you treat the stenosis before you put in the sphincter? Do you do it at the same time, or do you do it afterwards? And what I would say is you probably want to you probably want to treat the stenosis prior and try to assess the stability. And I say try because you're never going to get a guarantee. And if you do have to do something afterwards, just be very, very careful. You know, the mucosa, you don't want to rough it up. You don't want to use large instruments. There's a few strategies you can use, and I'm sure we'll talk about that later. Prophylactic antibiotics should be used. We've seen that, at least from the AUA, the guidelines is a first-generation cephalosporin or vancomycin plus gentamicin. There was a paper in this month's Journal of Urology, I believe, that is questioning whether those AUA guidelines for prosthetic surgery, this was more for penile implants, is really appropriate, but this is still the guidelines right now. You want to try to ensure low bacterial counts. If there's a UTI, treat it. You want to have a good skin prep. Radiated patients do have increased risks of reoperation. They have increased risks of erosion. And there's a question about adjuvant radiation timing, meaning if someone's had a prostatectomy and they have profound incontinence, but they're going to need radiation, should you do the sphincter prior to the radiation when the tissue is in the best quality, or do you wait till afterwards? Now, I will say that it is actually difficult sometimes to get a really good urine sample from someone who's profoundly incontinent. You could use a catheter, et cetera, but often you will get mixed flora. So it's a question of how you treat these people. Do you treat them preoperatively, and often I do if I am suspicious that they have something else going on, or do you just treat them with prophylactic antibiotics at the time? Detrusor overactivity. This is something that the panel recommends should be treated prior to surgery, but I will say on a practical level, it is sometimes difficult to really figure out how much detrusor overactivity is playing into their continence. So, for example, if someone has very profound stress urinary incontinence, they can have very mild detrusor overactivity, and it will lead to more incontinence. And so if the outlet is repaired, then they may have mild detrusor overactivity, or it may be something they don't recognize at all, and it only becomes manifest after you've done something like an artificial sphincter, in which case you need to treat them by whatever means. So while you think this is a good ad for doing urodynamics are helpful sometimes if they can hold in their urine and you're putting a clamp around the catheter. It depends how bad their incontinence is. You may be able to elucidate this, and you may not. Preoperative topical scrub is recommended. Current recommendations are chlorhexidine and alcohol as sort of being the best thing to do. Operatively, you can do these in a couple of positions, lithotomy or supine, but the panel does recommend that the perineal approach is the superior approach. While a lot of hospitals, you can really only get clippers this time to take off hair. Of course, we know that data is based on chest and abdomen, and really clippers can be a bit of mayhem down in the perineal and the scrotal area. So surgeons should be allowed to use their thing of choice with clippers or razors to get off the hair. Chlorhexidine alcohol is superior to the sort of more traditional povidone iodine. Urethral dissection should be done sharply, and then the urethral integrity should be confirmed. I see this a lot. I get a lot of consults for, quote, early erosion of these sphincters, but you know it's not early erosion. That's not typically a thing. It's someone who bluntly dissected, and most of the time it's going to work, and sometimes it doesn't. But if you don't look for it, you're not going to recognize it, and the patient is going to suffer as a result. The standard dissection is periurethral, but transcorporal may be used, and there are lots of situations where that's an appropriate thing to do. And you want to think about whether there's what you're going to do if either a penile prosthesis is already in place or whether the patient's contemplating it. And the scenario is fairly common, where a patient with pretty profound incontinence comes in and they say they have really no interest in their erectile function. But once they're dry, they sort of develop a new interest, they and their partner. And so it's certainly the case that you may be putting in a prosthetic down the road. I wanted to show this picture because this is a case from last week where you can see that the cuff The old cuff, which was done with a penoscrotal approach by a partner of mine who'd retired, is tiny, measured about 2 centimeters. And you can see the new cuff side is many, many centimeters away. So that's really the problem with the penoscrotal approach. It's not that you can't do it. It's that it's very easy to do a very bad job. And so you just probably don't want to do it. It's easier to do a good job if you go perineally. Operatively, if you do a transcorporal approach, you should close the edges. Sometimes it's tempting when you're looking at it. It doesn't look like it's bleeding very much, but they can bleed. They can bleed a lot. So you probably want to close those edges behind the cuff. Dissection for a transcorporal generally should be done distal to the cruce, although that's not always possible. You really want to avoid undersizing the cuff. Now that's really true in all of AUS. You want to avoid undersizing, but it's particularly true if you're doing transcorporal. The tunica just does not have the pliability of the other tissue, and you're going to have profound retention. For sizing, again, you don't want to undersize. If you're going to err on one side or the other, you want to make it on the slightly larger side. Dr. Brandis had a nice paper showing how you can do some cuff modifications to get exactly the size you want, and we do that pretty frequently, and it's easy to do. Inhibizone. In the United States, really a lot of the sphincters that we're using have inhibizone, but there's not that same kind of data that really supports the use of inhibizone in the artificial sphincter. It's not like the data that exists in the penile implants. Filling solution, you can use saline, or you can use one of the many sort of contrast regimens that's recommended by the manufacturer. But I think on a practical level, there's really no reason to use contrast. I've never found the idea to be helpful, because you can assess, for example, the pressure regulating balloon with imaging, either CT or ultrasound, and if there's a problem with the system, you're probably going to replace the entire system. So contrast and looking at these specific elements is just not that helpful for me. Pressure regulating balloons, the vast majority that are put in the U.S. and outside of the U.S. are going to be the 61 to 70 centimeter of water. That's not appropriate for everyone, and there are definitely situations in which you might want to use a higher pressure one. Now, there is, of course, a lower pressure one available. That's the 51 to 60, but I have not found that to be helpful even a little bit. The idea, of course, is to put less pressure in the urethra, especially in a radiated patient, to prevent atrophy, but in my experience when I've had this in the past is that what it really does is just not give you enough continence. The pressure-regulating balloon works within a certain range. It's not one of these things where the more fluid you put in, the more pressure it gives. And I have seen people make that argument, but it's just not true. This works within a range. So you want to put in about 22 to 27 cc's in the cuff, because, in the balloon, because the cuff is empty, and then when the cuff is full, about 2 cc's will go into the cuff. These balloons can be placed in a traditional location, space of Retzius, if that's there. They can be placed intra-abdominally, but it was discussed earlier why that may not be a great idea, although traditionally that's been done. Or they can be placed in what they call ectopic. That's a pretty general term, but ectopic really should refer to anything that's under the fascia. They do not work well if placed subcutaneously. I've seen people put these PRBs in the scrotal area if the patient has had an orchiectomy. That does not work well. I've seen them being placed subcutaneously, also does not work well. The pump needs to be in a place that is very, very easy to manipulate. The patient is going to be using this many, many times a day. It should be in the dependent scrotum, anterior to the testicle. Connections, these should be quick connect systems, and in the case of the revision, generally you want to replace the tubing in the quick connect systems. It was mentioned earlier that the quick connect systems are really not indicated to be used in the setting of a revision, only for the original, so you want to replace those. The device should be cycled and visualized to assess function, and the closure should be multi-layered with lots and lots of irrigation. We use Irricept now, and that was talked about a little the other day, but certainly you can use what irrigation you choose, including saline. Postoperatively, you want to leave in a small catheter, and you want to leave it in for as little time as you can get away with. We usually use a 12, and we try to keep it in for no more than 24 hours. There is no evidence that supports the use of postoperative antibiotics. I, like Dr. Westney, have had a lot of trouble weaning myself off of this practice, and I'm down to 24 hours, but I haven't honestly got myself down to just using the preoperative antibiotics. Limit physical activity and lifting for about 6 weeks afterwards. Virgin AUSs are typically activated at about 4 to 6 weeks afterwards. There's really no data whatsoever on when you should reactivate these in revisions. I do it depending on the situation, but typically 6 weeks is still the case. The patient should wear a MediAlert bracelet and should avoid perineal pressure and be very aware of the risks of catheterization. This cannot be overemphasized, and I would say as a practical point of view, the patient needs to tell everyone, and I mean everyone. They need to tell their spouse, they need to tell their family, they need to tell their friends that they have one of these things. The number one cause of erosion for me is iatrogenic. It's probably the number one cause for all of you. Postoperatively, you want to see them back and assess whether this has been adequate for them. Maybe you've unmasked some detrusor overactivity. Maybe things are not working as well as you'd like. Then you want to see them periodically. You want them to contact you immediately if there's any question about erosion or problems. Now, troubleshooting. These different scenarios may or may not need intervention. So if a patient is using a confidence pad or they're having some leak with strenuous physical activity, that's fine. That's totally reasonable. Post-micturition dribble is common. But you do want to be worried about the elevated storage pressures or having overflow. That's something that would need intervention potentially. Pseudoincontinence is that feeling when the urine goes into the proximal urethra, but it's not actually incontinence, so patients can be reassured. Technical aspects, there can be reduction in the system pressure, for example, a leak in the tubing. A cuff could have been oversized, may need to be downsized. Air bubbles or some distortion of the tubing can cause problems. Or improper engagement of the cuff tab. I've operated on a patient where they had a sphincter and they said it never worked for them. We went in, lo and behold, the surgeon had either neglected or forgotten to actually attach the cuff, and so the cuff was just laying wide open. Of course, that's not going to work well. I'm not going to go through this whole slide here, but you can see the potential findings on these different interventions and then what you might do to treat them. I circled a couple that I think warrant a little bit more highlighting. It's hard to assess people for their cognitive ability to use these cuffs, but it's also hard to predict the future and what's going to happen to them in terms of dementia or other problems. But this is in a way is somewhat of an inevitability. The patient gets older and maybe they no longer have either the physical dexterity or the mental capability of using this, and that needs to be taken into account. And sometimes we will deactivate these things if that's a question. In terms of treatment, you can also see one of the things that's proposed is an additional cuff. I'm going to get back to that in a second, but I would say that is not a good idea. Subcuff atrophy. This is really a diagnosis of exclusion. You can get a good idea cystoscopically, and you have a few treatment options. You can downsize, you can move the cuff, which I would say more proximally if that's available to you. Tandem cuff, come back to that, transcorporal cuff or increasing PRB pressure. Tandem cuff, I think, really should be condemned. It does improve continence in the very short term, but if you look at more than maybe 6 months, the continence is no different at all, but the complication rate goes way up, especially for the distal cuff with erosion and so forth. Higher PRB pressure is not something that you can use as just a substitute for doing a good job, meaning a higher PRB pressure may be appropriate in certain situations, but if a patient has had an AUS in for a long time and they have significant subcuff atrophy, increasing the pressure is not going to help. There is a concern if you increase the pressure that you're going to have earlier subcuff atrophy or even erosion, but at least in our studies that has not been borne out at all. Infection, you want to look for erosion. If that happens, you want to explant the entire device and you want to delay the implantation. The salvage does not really have a role in AUS. There are some reasons you might remove the cuff if there's a particular problem in the immediate postoperative period. Maybe you do single component, but generally you're not going to do that. How do you address the eroded urethra? There are lots of ways of doing it. Hopefully we can talk about that later. But really the studies that exist say, well, it seems to not matter that much. If it's a big erosion, you're going to get a stricture, less likely if you don't, but the actual way you treat it may not be that important. Mechanical failure, you generally want to replace the whole thing. And if you put in a new cuff after an erosion, how do you do it? There's different ways. You know, I would tend to go toward transcorporal, but there are a couple ways you could approach it. And that's it. Thank you very much for your time.